Hi, Andrew Penn back again to talk about one of the more challenging areas of bipolar disorder, which is treating bipolar depression. That this is a condition which causes significant burden for our patients. And I want to talk about a very thorny issue of the pros and cons of using antidepressants in managing this condition. And I want to highlight the benefit of lamotrigine and how to use it safely. So we'll use a medication algorithm to approach bipolar depression and think carefully about how we want to use antidepressants. So bipolar depression, unfortunately, comprises a large portion of the time that people with bipolar disorder experience, and it can be a profound kind of depression. This is a report from Emil Kraepelin, who was one of the sort of fathers of contemporary psychiatry and really was one of the first people to identify this condition and as a part of this larger picture of mania followed by depression. But that this can be a very severe depression and can often be accompanied with suicidal ideation. So our treatment here is most clear at the top. So lithium and lamotrigine should be standards, quetiapine, lamotrigine, or lamotrigine monotherapies, and then combinations of different medications. So the things that have clear indication would be lithium, lamotrigine, quetiapine, and the other atypical antipsychotics, lorazepam and cariprazine, and also olanzapine fluoxetine combination, which is not commonly used. But then as we go further on down the line here, you can see things get kind of murky, and that's why I say beyond here be dragons, because it's not very clear what we should do next at these stages. And unfortunately, this is more common than I would like it to be. But the main thing I want to point out here is that those top two lines should really be your main go-to medications for managing depression in bipolar disorder. Now, what about antidepressants? Why not just use an antidepressant? Well, some people would say you should. They say that, bipolar has a high morbidity of depression. Antidepressants work, that the risk of switching to a manic state is relatively low, and this is a condition that untreated can have serious consequences. Now, on the opposite side, which I tend to lean a little more towards, is this idea that antidepressants are actually mood destabilizing, and that they can cause short-term manic switches, but more importantly, they cause this longer-term mood destabilization. Sometimes people call this mixity or cyclicity, where there's more alternating between poles and more mixed states. And that those states might actually represent a higher risk for suicide. And that frankly, there are better agents out there, better mood stabilizing agents to use than antidepressants. Now, do antidepressants work in bipolar disorder? They do, and that's part of the challenge, is that we can definitely get a short-term benefit from antidepressant treatment, and this is a comparison of venlafaxine, sertraline, and bupropion, and you can see from the dark green that many people responded to their bipolar depression, responded to it, and for some people, they actually went into full remission. So why not just go ahead and use these? Well, there's always the risk of switching to mania, now full-blown mania. Now, this may not be as common as we once thought, because this was definitely the case with the tricyclic antidepressants, which venlafaxine is probably most similar to, being a serotonin norepinephrine reuptake inhibitor. But the risk to switching with sertraline was not zero. With bupropion, it was relatively low. And so that's where I feel confident. If I am going to use an antidepressant, I typically use bupropion, and there's a clinical pearl for you. But if we look at these patients over time, you see this is listed as odds ratio. So when the odds ratio is 2, it's twice as likely to happen as the other condition. And so you can see there's a clear liability for switching over time to venlafaxine. So this is something I generally stay away from. Sertraline, not zero risk. Bupropion, approaching a odds ratio of 1, which would mean that there's no difference in the likelihood of a switch when using bupropion. So again, more reasons that I feel safer using bupropion. Now, this is a very interesting study that looked at, so oftentimes in these antidepressant trials, we've looked at the possibility of a big switch. And what this did is they got people well. So they got people well, these are bipolar 2 folks who either got well on fluoxetine, on lithium, or on a placebo, which of course can happen. And then they followed them over time for over a year in some cases. And that's this regression survival analysis, sorry, in the top left here. And you can see that the people that did the best were actually people on either placebo or on lithium. But if we look at their day-to-day function, that's these jaggedy lines to the right. You can see you can see on the top, this is, so when they ask people day to day what sort of symptoms they were having, and this is a measurement of mania, you can see that the people on fluoxetine had much more of this kind of jaggedy path, this sawtooth path, than the people who were on lithium, or even the people on placebos. So this is an interesting piece of evidence that indicates that while antidepressants may work in bipolar 2, they may contribute to a more jaggedy, more mixed state, more small periods of mania clinical presentation. So we want to think carefully about that. And we know that when people are younger, so this is, you can see that the pinnacle of risk appears to be treating young people between the ages of 10 and 14, that their number needed to harm is relatively relatively high, sorry. Sorry, I misspoke that. That the percent reporting a manic switch would be this dark purple bar. So about 10% of people between the age of 10 to 14 being treated with antidepressants reported a manic switch. So that's concerning. So the bottom line for me is that the benefit for antidepressants in bipolar patients may be fairly limited. So if I am going to use it, I usually use it just to get them out of that difficult period, and then I try and taper them off. And I usually only do this if I'm also using a concurrent mood stabilizer such as lithium. And that if the younger patient is, the more apprehensive I am to do that. And if I am going to use an antidepressant, I'm going to probably use bupropion. And it's also worth considering that if you have a patient who has been on an antidepressant, who is starting to show more instability, more mixed states, more frequent switches, you might want to think about actually getting them off the antidepressant as your first move. Now, what can we do instead of using antidepressants? Well, I've talked about lithium. I'm going to talk more about lamotrigine and quetiapine, but there's also things such as exercise and cognitive behavioral therapy and light restriction. So this is where you have somebody expose themselves to bright light first thing in the morning for a half an hour or so, preferably while they're outside getting some exercise would be even better. And then as the evening goes on, you have them restrict the amount of light they're getting. And also don't allow them to sleep for excessive periods of time. It's very common in bipolar depression to have this significant drop off increase in the amount of sleep that is needed. And then you can also do things such as adding fish oil, which may have a modest effect, and making sure that their thyroid is working well. Now, what about lamotrigine? So lamotrigine has a great antidepressant prevention effect. So by that, I mean, it tends to prevent future episodes of depression. The downside is it doesn't really prevent mania at all. Most people tolerate it very well, and this should not be a monotherapy in people with bipolar 1 because it's not going to protect them against their manic episodes. And honestly, it's often started when people are in an acute depressive episode, but probably what happens there is just the passage of time, and the depression was going to get better anyways, because in the drug company studies that GlaxoSmithKline did, they did not find that that acute depression particularly responded to lamotrigine. But what it seems to do is it seems to prevent future episodes. So I think of this as sort of an anti-cycling drug. If you combine it with lithium, you generally get more robust responses. So I'm a fan of the lithium lamotrigine combination. Lamotrigine, as I said, is usually quite well tolerated, usually because we're starting it at such a low dose. But the biggest concern that we have is this rash. And we'll talk more about that in detail here. So there's two types of rash on this. One is a benign rash, which can happen to about 5 to 10% of people. And these are sort of these big blotchy red spots like you can see on this person's legs. And they're not painful. The person is not particularly systemically sick. And this is what we consider a benign rash. It will typically go away on its own. What's more concerning is Stevens-Johnson syndrome. So Stevens-Johnson syndrome can happen to anywhere, the estimates are anywhere between 1 to 2 in 1,000 to 1 to 2 in 10,000. And with this, you get these sort of punctate, bullseye-like rash marks that become confluent, like this gentleman's chest. And they're quite painful and blistered. There's often a fever. They often show up in the mouth. the person is quite obviously ill. And that's why you're not going to miss this. The patient's certainly not going to miss this. But when I talk about the rash, I always tell people important things to remember. If this doesn't show up in the first 2 months, it's probably never going to show up as long as you continue to take the medication consistently. If you stop the medication for more than 5 days, we have to restart the taper up. But in general, if this is going to show up, it's going to show up early. If people get any kind of rash, I always tell them to come on in and we'll get them seen by a dermatology. I also tell them, don't change your laundry detergent, don't change your soap, things that might cause a benign rash that you might mistake for this, because people get very hypervigilant, as you can imagine. And I tell them, I would not Google Stevens-Johnson syndrome unless you want to scare yourself. But I write it on the prescription. I say, if you get any rash, stop the medication and contact me immediately. And I also just want to put this in perspective that Stevens-Johnson syndrome is not just limited to lamotrigine. The biggest offender of this is actually sulfa antibiotics. And I bet the last time you had Septra, nobody warned you about this possibility. So lamotrigine does confer a risk for Stevens-Johnson, but it's fairly low. It's actually lower than carbamazepine. Now, back when this was a branded med, it came in these very handy packages, but you can certainly write this on your prescription. And so this is for somebody who's not on valproate. You're going to start at 25 milligrams a day for 2 weeks. And then you're going to do 50 milligrams a day for 2 weeks. Then you're going to do 100 milligrams for an additional week. Now you're at starting dose. And oftentimes that's enough, but many people require more. My experience has been that I'll typically go to 200-300 milligrams of this. And in neurology for seizure control, which is what this medication was originally used for, they go higher than that. But I always tell people this is a slow moving agent. You got to be patient with it. Now, drug-drug interactions with lamotrigine are important to be aware of. So when somebody's on valproate, it inhibits the clearance of that lamotrigine. So there's lamotrigine going through those gluconeryl transferases we talked about in the first class, and then you add an inhibitor. So now that mechanism is going more slowly. So what that means is you're going to have increased lamotrigine levels and a potentially higher risk for a rash. So if you're going to give lamotrigine to somebody who is taking valproate, this is what you need to do. First of all, you drop the level of valproate by 50%, usually for 5 days. That gets you down to a new steady state. And then you're going to introduce lamotrigine, but you're going to do it at half the pace. So now it's 25 milligrams every other day for 2 weeks, 25 milligrams a day for 2 weeks, 50 milligrams a day for 1 week, and then you get up to 100 milligrams. So we're going a lot more slowly in bringing that up to speed to lower the risk of a rash. Now, on the flip side, carbamazepine actually induces that same enzyme. So there's your lamotrigine going through, and now we add carbamazepine. So whew, those things are going lickety-split, right? So what's going to happen is you're going to have decreased lamotrigine levels when you add carbamazepine to the picture. Same with phenobarbital, primidone, and dilantin. So when you do that, you got to double up on the dose. You got to do 50 milligrams every day for 2 weeks, and then 50 milligrams twice a day for 2 weeks, then 100 milligrams a day going forward, okay? And often you'll need to use higher doses of the lamotrigine to account for the induction that is caused by the carbamazepine, to not have that those levels drop. And then finally, if you're going to add valproate to somebody who's already taking lamotrigine, you're going to reduce the lamotrigine level by 50% before you start the valproate. And then you're going to gradually go back up on the valproate levels. And you're going to be really careful around looking for a rash. So in summary, depression is the biggest problem with bipolar disorder, not mania. And it's even worse with bipolar 2. And lithium should remain our mainstay, and lamotrigine not far behind. And we can alleviate the risks of lamotrigine by going slowly, being aware of drug-drug interactions, and of course, always monitoring for any kind of rash or Stevens-Johnson syndrome. I hope this is helpful. Thanks.